Thank you, Dr. Neha Kakkar, Sahani Sir, and Dr. Surya Singh Bahadia. Good evening, good afternoon, and good morning. This is the 1492nd day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. D. Balachandran from Chennai. Let us begin the session with 1 minute silent prayer. Thank you all. As you all know, that the International Forum for Promoting Homeopathy is about to celebrate the 1500th day on the 9th of this month, but we have arranged a 1 week celebration from 3rd of October to 9th of October, and we will be discussing about one of the major subjects, that is the treatment for the homeopathic treatment for humans, animals, and vegetable kingdom. And we will have different sessions from different guests from international level, and there will be at least 3 participants, faculties will be talking on each day. And that's the beauty of this session. We have arranged several sessions. Last time at the 1000 day, we have arranged 1 month celebration from dedicated to different countries, participating countries, and this time it's arranged in a different way. As you know, the first session of the day is over, our Hindi session from 7:30 to 8:30, and 8:30 to 9:30 we have the international session in English, and 9:30 to 10:30 we have a local language session in Malayalam. And all these sessions, videos will be uploading tomorrow itself, so that those who miss us in any part of the session, we can watch again, and you can subscribe the video without a penny, and that too as by searching IFPH Homeopathy. And let me introduce our guest of the day. As you all know, that it is Professor Dr. D. Balachandran from Chennai. Doctor has completed MD in Pediatrics, and then working as a senior medical officer, Homeopathy AIIMS Patna, and is a former professor and HOD of the Department of Practice of Medicine, RKDF University, Bhopal. Dr. Balachandran is a well-known doctor who has presented so many sessions in this forum. All these sessions were really excellent. I congratulate Dr. Balachandran for his excellent presentation, and let us welcome Dr. Balachandran for the session today. And the session Doctor will be talking about one of the important subjects in homeopathy, the practical understanding of the mind chapter. As you all know, that the mind is the thing that is very, very important in deciding the right remedy and right medicine in homeopathy. So we welcome Professor Dr. Balachandran. Welcome, Doctor.
Thank you, Dr. Danesh, for the wonderful introduction. Good evening, one and all. Let us go into today's session of practical utilization of mind rubrics from the repertory. Let me share my screen first of all. I think the screen is visible.
Yes. Everything.
And my voice is audible, of course.
Yes. Everything fine.
Okay, fine. Right. So this has been already done in the Hindi session, but as this is the English session, those who have missed the Hindi session can log in today to understand in depth about the how to utilize mind rubrics in the clinical practice. This is today's topic. Let's go. Right. So a disclaimer here. This is not for those who know very well to interpret the mind rubrics in the practice. Of course, there are many doctors over here in this platform, many senior most practitioners, students, of course, internees. So the most important, vital or pivotal part of the homeopathy is regarding the understanding of the mind status or mental status of the patient whenever we are going to interact with the patient in the case checking part. And one of the most toughest or the most difficult task in the homeopathy case checking is to probe into the patient's mind and to understand the mental status of the patient. There are certain lame excuses given by certain doctors saying that I don't get the mental symptoms from the patient, or the patient does not reveal any mental symptoms, or the patient does not say any symptoms regarding to the mind. So what to do? There is a lapse or there is a lacunae. So how to fill the lacunae? Concentrate on the physical generals. Ask about the appetite, thirst, sleep, dreams, stool, urine, sweat, thermal reactions. Okay, if in case of females, about the menstrual history, desires, aversions, intolerance. So all these comes under the physical genitals, of course. So what most of the practitioner does is, instead of what to say, giving time or dedicating time to learn or understand the art of probing the mind, rather they are going for the short cut method of tapping into the physical genitals, prescribing upon the physical genitals, or rather go into the particulars of the patient's complaint, try to catch hold of any PQR symptoms or the uncommon peculiar symptoms. And if you get 3 symptoms, then you try to prescribe upon the the particular uncommon peculiar symptoms of the patient. So this is how the practice has been going till now. But I tell you, probing the mind is very easy. One is that the doctor should be diligent enough to have a keen sense to understand the patient who is sitting in front of us, and to give close attention to what they are doing. The patient always, it so happens that the patient may not reveal everything by the mouth. The patient may does some gesture. The body language of the patient might change. The way in which the patient talks to you, the way in which the patient comes to you, sits in front of you, try to interact with you. If you're asking any questions, that whether the patient is hesitant to answer, or whether the patient is afraid of your questioning, or whether the patient is not interested in answering. So all these give some of the ideas regarding what is the current status of the patient's mind. So it's pretty easy. I hope everyone can able to probe into the mind, provided that they dedicate some time with the patient, or they dedicate some time to learn the skill. And when you are going to first put it in the practice for the very first time, it will be difficult. But as you see 10, 20 patients, 50 patients, 100 patients, then it becomes very easy. In a jiffy, you can able to understand the patients. So this is one such attempt to make those understand, those who are keen to understand how to probe into the patient's mind. This will be one such technique or skill which you can cultivate on your own by seeing patients and get a hold of it, get a mastery over it. So I hope everyone has certain preforma or a kind of case taking preforma for how to tap into the mind. So generally what they ask is, after the physical generals and mental, the particulars are over, first you start with the particulars, try to analyze the patient symptoms, and then go with the physical generals. And after which you go to the mind, you ask the patient, are you angry? Or else you ask the patient, are you fastidious? Or you ask the patient, are you happy? Are you sad? So if you put a direct question to the patient, sometimes the patient may get confused, or the patient may be hesitant enough to answer. No one will admit that they are lascivious, or no one will admit that they are dirty. No one will admit that they have a short temper. No one will admit that they have the desire to kill others or hurt others. They try to hide it away. But if you ask the family members or those attendants with the patient, then you can know better about the patient's state of mind, which he is not willing to open up in front of you. So the patient's version, as well as those version which is put forward by the attendants along with the patients or the family members, should also be given importance, right? So every homeopathic physician knows eliciting the characteristic physical symptoms is comparatively easy, and at any rate it is not as difficult as understanding the state of mind and disposition. The result is that physicians who make an earnest attempt to understand the mental status of the patient are very few. This is due to the simple reason that they have not cared to train themselves in this art, probably excusing themselves that it is too time consuming. Consequently, patients are deprived of the best benefit with which homeopathy as a science is capable of giving. So there are different alternative methods for probing the mind. There is Shegel's method for eliciting the mind symptoms. You have the Shankaran's method. You have the Praful Vijaykar's method. You have Vitolka's method. Likewise, you have several different methods to make the task or the mastery of probing the mind easier in one way or the other. They have their own way of getting into the mind. So I'm not saying that one method is right, other method is wrong. Even Dr. Hahnemann has emphasized the importance of mind in his organ of medicine. But this is one easiest way by which you can able to probe into the mind symptoms, right? So what is the importance of mind according to Dr. Hahnemann? If you see the aphorism 84 in the 6th edition of Organon, it is given by Hahnemann that the patient details the history of his sufferings. Those about him tell what they heard him complain of, how he has behaved, and what they have noticed in him. Kindly see those words which are highlighted in red ink is very, very important. So how he has behaved and what they have noticed in him means the appearance, the behavioral change. The physician sees, hears, and remarks by his other senses what there is of an altered or unusual character about him. He writes down accurately all that the patient and his friends have told him in the very expressions used by them. So do not try to write in your own way. Whatever the patient says, try to write in his own sentence what he has said, and later on you try to convert it into your rubric. Okay. Uh, Keeping silence himself, he allows them to say all that they have to say and refrains from interrupting them unless they wander off to other matters. So the first phase is a passive stance. You have to keep quiet, silent, kindly observe what is happening, the changes, what is visible in the patient, and try to understand his way of explaining the symptoms to you, and ask the attendants about how he has behaved in the past few weeks or past few months, depending upon whether it is acute or chronic, and what changes they have noticed in him, which is of an unusual character. Right? That's it. That is there in the aphorism number 84. Then comes aphorism number 210. Hahnemann says in the middle of this aphorism, in all cases of disease, we are called on to cure the state of the patient's disposition, which is to be particularly noted, along with the totality of the symptoms. If we would trace an accurate picture of the disease in order to be able therefrom to treat it homeopathically with success. So what we have to pay heed to is the patient's disposition. Disposition means what? What's the current mental status of the patient when he is in front of you for the case checking or in front of you during the consultation time. And next, in aphorism 211, Hahnemann says in the middle of the aphorism that the state of the disposition of the patient often chiefly determines the selection of the homeopathic remedy as being a decidedly characteristic symptom, which can least of all remain concealed from the accurately observing physician. So again, he stresses the importance of the disposition of the patient, which has to be given heed while case checking. Next, in aphorism number 213, he says, we shall therefore never be able to cure conformably to nature, that is to say homeopathically, if we do not in every case of disease, even in such as acute, observe along with other symptoms those relating to the changes in the state of the mind and the disposition. So physical generals, the physical generals particulars are important. Along with that, the mental generals, which contains the changes in the state of the mind and disposition, should also be given importance along with it. And if we do not select for the patient's relief from among the medicines a disease force, which in addition to the similarity of its other symptoms to those of the disease, is also capable of producing a similar state of the disposition of the mind. So once if you get the totality of the symptoms, which includes the physical generals, mental generals, as well as the particulars, you are now trying to find out a similar remedy or similimum, which has the same disposition as that of the patient in front of you, together with the other physical generals and the particulars even. So he says in the footnote, thus aconite will seldom or never effect a rapid or permanent cure in a patient of a quiet, calm, equable disposition. So you know about the aconite state of mind. There's a fear, fright, anxiety in the patient. Okay, he predicts the day or date of death, fear of death, which is very predominant in the patient. His restlessness, mental restlessness is very predominant. Okay, so all these are there given in the mind of the aconite. So if suppose you have a patient who is of a quiet and calm or equable disposition, just like a pulsatilla, would you prescribe aconite? No. Why? Even if the patient is having the particular symptoms matching to that of the aconite, but still the mental generals are contradicting. So you won't go for aconite, rather you go for some other medicines which has a disposition which is quite calm and equable. And just as little will Naxomica be serviceable when the disposition is mild and phlegmatic. You know about the Naxomica mentality. Naxomica is having a choleric mentality or the choleric disposition, whereby the patient is having immense amount of what you say, fastidiousness, irritability of the mind, okay, easily get angered, of a short-tempered disposition, fastidious in nature, okay. So all these there will be there in the mind of the Naxomica patient. And if suppose you have a patient whose disposition is mild and phlegmatic, which is contradictory to Naxomica, Naxomica will seldom be indicated. You have to go for other medicines which has the mild phlegmatic disposition like that of the patient. Pulsatilla, where it is a happy, gay, and obstinate, or Ignatia, where it is imperturbable and disposed neither to be frightened or nor vexed. So these are the examples what Dr. Hahnemann gives regarding the contradictory nature of the patient as well as the drug with regard to the mental generals, and whereby it is contraindicated in this case, so that a better similimum has to be selected from among the other medicines, as it is not matching with that of the disposition of the patient. So that's clear in aphorism number 213 footnote. This is the case checking process. I hope you know this well. I'm not saying anything new to you, but I'm just brushing up what Dr. Hahnemann has said regarding the case checking process. So what I found out to make Hahnemannian's description aphorism in a simpler way, whenever you take a case, there are two phases where you have to adapt. Okay, right. So first phase is a passive phase or passive stance. Stance means what? The behavior what you adapt while during the case checking process. So when you begin with the case checking, you first adapt the first phase, which is called as the passive stance. In passive stance, what is your duty? Your duty is to remain silent. Your duty is just to observe the patient and try to give your senses a sharp, sharp attention to what the patient says, the manner in which the patient says to you, the manner in which the patient sits in front of you, and try to just observe the patient regarding his behavioral changes, what is happening. So you are not going to say anything. You are just going to keep silent. You are just going to simply observe what the patient is doing in front of you, how he is trying to say his symptoms, and in what way he is utters these symptoms. And if you notice any changes in the body language, you can simply observe. And in this phase, what it is called as the passive stance, you're going to remain silent. You're just going to let the patient talk and just remain silent and observe the patient. Okay, so this is the passive stance. So what happens in passive stance? Ask the patient to narrate the entire life situation, including his mental, emotional disposition, hopes, aspirations, and frustrations and their effect upon them. Ask the patient to cite actual instances of their behavior to enable us to judge the reactions in proper context. So ask the patient to say any real life situations or real life instances which has happened in his life, to narrate those instances so that we can have a better catch regarding the substantiality of what the patient is about to saying to you. Encourage the patient to tell even such peculiar sensations and feelings which they might consider laughable and unimportant. They should be told that these strange and peculiar symptoms are in fact the most important for us in selecting the remedy. So sometimes the patient may think that the doctor would laugh or the doctor would find me silly when I say these symptoms. How can I able to say? The patient will not say that. Suppose, let me say an example. If suppose there is an aloes patient, the patient might be having a sensation as if the stool would come along when the patient is going to pass flatus. So this is a embarrassing situation which the patient might have faced, but he would not say in front of you because you might think that the patient is grown up and still he is soiling his underpants. So you might you get an opinion about the patient. You might be prejudiced regarding the patient's way. So he might conceal this from you. Rather, he would say that, sir, I'm having a diarrhea episode. I'm passing stool, which is yellowish, liquid, watery, about 10 to 20 times per day. But if he is going to say this one word, that the sensation as if the stool might escape along while passing flatus, your selection of medicine is very easy. Or else you have to go to the repertory or the Bell's diarrhea. You have to see almost some 50 to 100 remedies, which all has these watery liquid yellowish stools, which will be difficult for you to jot down a particular remedy. So always you encourage the patient to say whatever they want to say, even if they find those silly or unimportant. For them, it might be unimportant or silly, but for us, it is going to have a huge weightage in selection of the simillimum. Thus, having been briefed adequately for narrating the case, the patient gives us a fairly good picture of their personality and present emotional makeup. All these helps us to make a tentative decision about the personality group or cluster to which they belong. So what is your duty now? You are going to remain silent. You are asking the patient to say whatever he wants to say. Of course, you can interrupt when the patient wavers to other matters which is not of importance to the current situation. And by listening carefully in the passive stance, what you are trying to interpret, you are now trying to place the patient in any of the personality group or clusters to which the patient might belong to. It is not prejudiceness, it is exact observation. And you are trying to put the patient under some listings of the clusters. Okay, so when the patient have narrated everything in a brief manner, you might have some assumption regarding whether the patient is a what kind of a patient are we dealing with? Are we dealing with a irritable, or are we dealing with an anxious, or are we dealing with a timid, or are we dealing with an ambitious patient? What patient is in front of us? Or is the patient having any antisocial traits? So such kind of opinion can come to your mind after the patient finishes his way of saying the things to you, right? When you watch any film, you can very well able to understand who is the hero, who is the villain, who is the joker, or who is the comedian, or who is having a character role. Everything you can able to interpret in a films. Why? Because when you see the characters, you can able to very well assess. A hero will be having always a heroic appearance. Okay, his dress will be very attractive, or the dress will be very neat and clean, so that it can attract the heroine's attention. Okay, the hero always does good things. The hero will never lie. The hero will have a charity. The hero will try to help others. So all these good characteristics will ultimately tell you that he is the hero because he's having those traits. Okay, he's brave, he's courageous, he is able to stand against injustice likewise. So by seeing all these traits, you can able to opinionate that this might be the hero of this picture because he's having all these traits. And you can very well know who is the villain of the film because the villain will be showcased in that particular manner, that he does some unjustful things. Okay, he try to hurt others. Okay, he try to snatch others property or the money from them. They do certain antisocial activities. Okay, they don't respect others, they don't respect the private places. So all these things, they lie, they cheat others. So all these characteristics, you will come to an opinion that he might be the villain because he's having all these characteristics traits. Likewise, when a patient is going to say to you all the symptoms in the passive stance, at the end you will get an opinion what cluster the patient would belong to. I will tell you what cluster is, right? Cluster means a group of traits which will try to characterize that person whether falling into this particular category, right? So that is about this passive stance. Now comes the active stance. So the first part is over. What you're doing in the first part, you're keeping silent. You're asking the patient to narrate all the symptoms in his own way. You're going to observe and you are going to notice the changes in the behavior of the patient, the body language, the gestures, and you're trying to also listen to the attenders, what they have to say about this particular patient. Sometimes they will support the patient's stance, or sometimes they would oppose the patient's way of answering the questions, which you would later interrogate with the attenders after sending the patient outside. Like, what is contradictory regarding this particular part? Why you have opposed that the patient is not so? So after completing this process, maintaining a passive stance, you will come to a opinion. Okay, it might be wrong, but you will come to opinion that the patient might belong to these clusters or this personality trait of these groupings. Okay, now coming to the active stance. Now you have to confirm whether you allocated the patient to that particular cluster, whether he really belongs to that cluster or he belongs to one or more other clusters. So how do you do? Unless and until you open your mouth and interfere or interrogate, it will never happen. So in active stance, now you are going to open up your mouth for the first time. You are going to now question the patients regarding certain things. Okay. So now it is the physician's turn to interrogate the patient for more details required to get a complete image of the patient. Quite often, even after proper briefing, the patients are not able to give full details about themselves. It is at this stage that many failures in eliciting full details occur because the doctor gets confused as to what questions to ask. Okay, when the patient completes whatever he wants to say, when you are going to go for the active stance, now arises the confusion what to ask the patient. Okay, in this way, in this particular active stance, every other doctors will have one other pattern of how they elicit the mind. That depends upon the pattern which their senior might have followed. It depends upon the pattern the doctors have followed to whom you might have worked as an apprentice, or the pattern might have followed which you regularly use in your practice, a set of questions what you put forward to the patient so that you get some mind symptoms. So it is not always rigid, it is dynamic. The questions might differ depending upon the patient's presentation in front of you. You cannot ask a stereotyped questions to all the patients. That might end in a failure. Okay. So now the problem arises is what question to ask. He meanders from one line of inquiry to another according to a set of pattern performed by habit. Such questioning becomes purposeless and ineffective. If you're going to follow a rigid pattern, then you will not get any answers. Okay. As a result, his conclusions about the patient's state of mind becomes erroneous. So by following this, you might come to an erroneous conclusion and your prescription might be wrong and you will not get the proper results what you should obtain. So how do we go about it? This situation can be avoided if the patient refers to the rubrics in one or the other of the personality groups or clusters, depending upon the nature of the emotional or mental disposition to which the patient predominantly belongs, as revealed when the patient was telling their part of the story. So how do you go to the active stance? How do you interrogate? After the passive stance, you have come to a opinion that the patient might be belonging to this particular cluster. Now try to ask questions regarding the rubrics in that particular cluster, but not directly, but indirect way to confirm whether the patient is belonging to that particular cluster or not. Now coming to what is cluster. See, these are the ruling characteristics of personality groups. We have two clusters here. One is cluster 1, which is indicated by an yellow color, and second is cluster 2, which is indicated by a light blue or sky blue color. So in each cluster, we have 9 categories. So we have category 1 to 9 in cluster 1, and we have category 10 to 18 in cluster 2. Now, why I have classified this into two clusters is because cluster 1, if you see, all these personality traits are nothing but an exaggerated normalcy. Always remember, when you are going to consider physiology and pathology regarding the mind, that is psychophysiology and psychopathology, or the psychology or the abnormal psychology, there is only a thin line of difference. Okay, if anything is exaggerated more than the normal, then that is placed under psychopathology. But if anything is grossly deviated from the normalcy, then it's a psychopathology, right? So this is how you categorize. If you see the disposition of category 1 to 9, all these are nothing but exaggerated normalcy in repertory, in whatever repertory it may be, whether you take Kent's repertory or synthetic repertory of Barthel and Wilklunker, or you take the synthesis repertory or the complete repertory, whatever rubric is given in the mind is all abnormal. They are not normalcy. You might find the word as fastidious. You might think that fastidiousness is a good trait actually, but it is nothing but an exaggerated normalcy. Means fastidious cleanliness is there, but if a person is over involved in cleaning, after every activity is going to clean his hands again and again, which is going to interfere in his day-to-day activities, then it is psychopathology. It is not a physiology, psychology, normal psychology. So all the rubrics starting from A to Z given in any repertory, whether it be Kent's repertory or synthetic repertory or synthesis or complete, whatever repertory it may be, all these things are nothing but exaggerated normalcy or gross pathological abnormalcy. Don't take it concern for the normal behavior of the patient. Okay, right. So that has been clarified. Now coming to the cluster 1, and cluster 2 is grossly deviated abnormalcy. So cluster 1 is exaggerated normalcy, which is a psychopathology again. And cluster 2 is a grossly deviant behavior from the normalcy, which is definitely a psychopathology. So cluster 1, if you see category 1, you classify the patient as a domineering or go-getter type. In category 2, we have the mild sensitive type. In category 3 of cluster 1, we have the anxious, fearful, timid personalities. In category 4, we have the restlessness personality. In category 5, we have the planning and thinking personalities. In category 6, we have the lascivious personalities, or those who are more involved with the sexual activities or sexual thoughts or sexual behavior. In category 7, we have the unsocial traits, or which is not socially acceptable in the society, doing unsocial activities like breakage of properties, setting things on fire. So all these kinds of things, hurting others, abusing others, all these are unsocial traits. And in category 8, we have the unsocial behavior. So trait is different, behavior is different. So trait is there in the individual, behavior is exhibited in different situations. Exhibiting the same type of traits is called as a behavior. And in category 9, we have destructiveness. The patient who has a lot of destructive activities, which is one of the characteristics of the unsocial traits. So this is regarding the category 1 to 9 belonging to cluster 1, whereby we have domineering, mild, anxious, fearful, timid, restlessness, planning and thinking, lascivious, unsocial traits, unsocial behavior, destructiveness categories. Okay. Now coming to cluster 2, it starts with category 10 and ends with category 18. Category 10, we have the sad melancholy disposition or sad melancholy personality, which is grossly deviated. In category 11, we have the extreme effects, which are expressions of extreme intensity like shock, anguish, rage. And in category 12, we have the dullness of the mind. In category 13, we have imbecility or idiocy. In category 14, we have mental alienation. Category 15, we have delusions. Category 16, we have habits and obsessions. Category 17, we have causations or ailments from any of the complaints, mental complaints regarding from any of the ailments. And category 18, we have aggravation or amelioration from, that is modalities. So all these comes under the cluster 2. So after the patient have finished narrating the complaints where you are going to adopt a passive stance. Now you are going to put the patient as belonging to any of these clusters, cluster 1 or cluster 2. And if at all it is in cluster 1, among which of the category would you place the patient? Whether it is category 1 or 2 or 3 or 4. Or likewise, if suppose you are going to find the narration of the patients as belonging to cluster 2 or grossly deviant behavior, in which of the category would you place the patient? So why we are doing this? To get a better understanding of what the patient's symptoms might be. That will help you in the active stance, right? Now, going forward, I don't think you have any doubts regarding this cluster classification. Cluster 1 is exaggerated normalcy. Cluster 2 is grossly deviant abnormalcy of the mind. Okay, right. Now, this has been explained here. Suppose you have categorized the patient as belonging to predominantly to category 1, that is domineering or go-getter type. You should now question him as to ascertain as to which one or more of the several rubrics given under this group conform to his mental disposition. The question should be tactfully worded in order to elicit the responses. For example, instead of asking whether he is domineering, ask him how he deals with his subordinates who are inefficient, and on the other side with superiors who are exacting. So instead of asking whether the patient is domineering or whether the patient is a dominant behavior or a dogmatic kind of individual, okay, rather you ask him, instead of asking whether he is dominating, you ask him how he deals with his subordinates. That means his juniors or his inferior workers or inferior class of people who is working under him. And similarly, ask him about how he deals with his superiors. So in that way, you can able to understand by his behavior to the juniors as well as the seniors whether he is dominating or not. An effective method is to pose hypothetical situations in day-to-day life relevant to each rubric in the group and ask how they react to them. By open anger or vexation felt internally, or by reserved displeasure or suppressed anger, by brooding, by dwelling on the event for long, by losing temper with the family or subordinates, by weeping alone, by anorexia, by taciturnity, or by sleeplessness, and so on. So you have to ask the patient to narrate real life instances under those groups which the patient has been categorized to, so that you can able to catch hold of the rubric, and you have to ask the patient how they react to that situation. Okay, what will be his behavioral change to that particular situation, how it has affected him, and what is his response to that particular situation, right? As far as possible, an attempt should be made to elicit actual instances of the type of behavior under discussion for confirmation. Always, always, always try to ask the patient to narrate instances from his real life situations where he faced one such condition, so that you can get a better grip about the patient's substantiality of his saying about the mind. Okay, because real life situation gives one additional advantage, that the patient is behaving in such way, so he might be confirmed that he is belonging to that particular group only, right? One more thing is that while eliciting the response to various rubrics under the group concerned, the patient may fall under some other groups also. Not necessary that when you are going to place the patient under the category 1 of cluster 1 as domineering or go-getter, not necessary that he will be falling under that particular category only. He might be having certain symptoms which might fall into cluster 2 of an imbecility or idiocy type also. So do not get into a prejudiced opinion that the patient is belonging to that one particular category. He might be belonging to some other categories of the same cluster or the different clusters also. So how do you find out? You have to rapidly, in between interrogation, try to put forward certain rubrics from the other groups also to confirm whether the patient is not falling under that group, and whether the patient is confirmatively coming under the particular group to which it has been placed. So in this way, the prejudiciousness can be taken apart. It is important to note that cases cannot come exclusively under one group. Therefore, while we start questions based on the rubrics in the predominant group, if symptoms belonging to another group are also found to be strong, they should also be considered. It is advisable to elicit the response to a few plausible rubrics under the other groups as well. This procedure gives us an assurance that we are on the right track and permits us to correct if we are mistaken. Right? So we can always correct ourselves if suppose the patient is trying, if you find out that the patient is falling under some other categories as well. This type of questioning on a right track eliminates the chance of missing some important aspects of the case and makes our case as broad-based and complete as possible. A lot of judgment on the part of the physician is called for in determining the relative value of the symptoms expressed through the rubrics while taking them for repertorization. While using the rubrics for repertorization, do not neglect to search for sub-rubric which may be appropriate to the case. So don't always stick onto the main rubric. If you think that the patient is anxious and the patient is having anxiety episodes, the sub rubric is what are the instances which provocates anxiety, or what are the time modalities or position modalities which creates an anxiety, what are the instances which produces anxiety, what are the accompanying symptoms along with anxiety. So these are placed on the sub rubrics of the main rubric of anxiety. So always try to find out the sub rubrics also if possible from the patient, and you try to get a better hold of the sub rubric if at all it is clearly indicated. While probing the mind, we should not neglect to elicit the patient's state of the mind in regard to the deepest instincts of life and survival, such as desire for company, approval and appreciation, sensitivity to hurt, accomplishment or frustration, sexual impulse and gratification, the manner in which he seeks relief and relaxation from the strains and stresses of life. Like he desired music, he is very religious, he is having indifference, he will not talk to anyone, he is apathetic, he wants to dance, okay, he loves to enjoy the rain, he wants to dance in the rain, or he would like to take his mind off by involving in some sexual activity, marital or extramarital, whatever it may be, by reading books. Okay, so these are some of the ways in which the patient try to de-stress himself. So that also has to be given importance while case checking. Now, how to probe the mind? I will give you some of the hints how you get into the cluster type. If suppose the patient belongs to the category 1 of cluster 1, that is dominating or go-getter, instead of asking the question whether you are dominating or whether you are domineering, instead you can go to the indirect way of asking like this. You must be quite ambitious to achieve whatever you have set your heart on. How do you react to obstacles in the way, natural or those created by others? What is the level of your anger when you are thwarted or opposed? So this is the indirect way of asking whether he is dominant or not. You are not putting the word dominant directly, but instead you are using the verbs like ambitious, or how do you tackle the obstacles on your way? What is the level of your anger when you are opposed, or when you are thwarted, or when you are disappointed? So all these things, the reaction of the patient, if really such instances happen in the life, will give you a better hold of whether the patient belongs to the dominating group or not. So this is the indirect way of questioning. You're not going to question him directly, but indirectly you put this question in such a way so that you can able to understand from the patient's response whether he is domineering or not. Right? Now, what are the rubrics to consider under the category 1 of cluster 1? The sub-rubrics or the rubrics which belongs to the domineering type includes ambition, amusement desires, anger irascibility, anger violent, audacity, cannot bear to be looked at, censorious, company desires, conscientious about trifles, consolation kind words aggravation, contemptuous, contradiction intolerant of, courageous, defiant, dictatorial, egotism, excitable, exhilaration, haughty, hurry, ideas abundant, impatient, impetuous, impolite, impulsive, indignation, industrious, irritability, loquacious, obstinate, rage, fury, reserved, rudeness, selfish, sulky, vanity, violent, vehement, vivacious. So all these rubrics can be considered for the patient when you are going to place him under the domineering or the category 1 of cluster 1 category, that is a go-getter type. So you can ask indirect questions regarding all the sub-rubrics or the rubrics given in the under the domineering category, and you can confirm whether the patient belongs to any of these rubrics. If so, you can take that rubric for sure. And always ask the patient to narrate from the real life instances, if any, or else you give a hypothetical situation to the patient, how he would react if such an instance has happened. And by the reaction, what the patient says, you can able to get a better hold of this rubric. Next is the second category, that is mild sensitive. How do you ask the patient this question? Indirect way. Will you go ahead with your plans and ideas in the teeth of opposition? What are your feelings towards such people who oppose you? When confronted by a determined opponent, will you avoid confrontation and compromise as the better part of the valor? So if suppose you are having a plan or idea that you want to execute to reach a goal, if suppose there is going to be an opposition coming under your way, how will you react to that opposition? You negotiate with them, you try to take a back step. If that is there, then you are mild and sensitive. But no, you will oppose your opponent and you go ahead forward, come whatever it may be, hurdles, I'll just kick it off and I will try to achieve my goal. If that is the case, then it comes under cluster 1 of domineering. That is category 1 of domineering or go-getter type. But if the patient is going to sulk inside and the patient is going to step backwards, they cannot able to face the opposition, or they cannot able to face the opponent. So instead they go to a timid mentality or mild category. They try to leave the plan and they try to find an alternative plan. In that case, the patient might be belonging to the category 2, that is mild sensitive category. Okay. Now, what are the rubrics coming under the mild sensitive type? Affectionate, benevolence, brooding, capricious, cheerful, consolation, amelioration, contented, credulous, injustice cannot support, irresolution, jesting, laughing, mildness, moods changeable, naive, offended easily, quiet disposition, quiet wants to be, rest desire for, secretive, sensitive, sensitive to noise, sensitive to odors, sensitive to pain, and servile. All these rubrics can be considered for mild sensitive patients. Now coming to the third category of anxious, fearful, and timid category. So how do you pose the question? You pose the question in such a way, are there any circumstances which cause a high degree of anxiety in you? That means any situation or any circumstances or any instances which provocate a high anxiety in you, tell me. Are you troubled by fears of one or the other? Of enemies, of robbers, of losing your job, of wife or husband being unfaithful, of incurable diseases, of being alone, of misfortune, or of loss of disposition in society, etc. So you're giving them a choice, or you're giving them an example. Like, these are some of the examples for causative fear. Are you having any of this, or if not all it is not there, then you try to tell what are the things you are afraid of. So that is about the anxiety and fearful and timid disposition in category 3 of cluster 1. The rubrics which can be taken are anxiety, anxiety when alone, anxiety of conscience, anxiety with fear, anxiety about health, anxiety during sleep, bashful, capricious, cares, worries full of, cautious, clinging to person, cowardice, despair, discouraged, fearsome, fear of being alone, fear of animals, fear of dark, death, impending disease, misfortune, strangers, 4-second feeling, frightened easily, high desire to, horrible things affect him, moods changeable, morose, peevish, religious, remorse, startled, slowness, sympathetic, timidity, tranquility, weeping, witty, and yielding. So these are the rubrics coming under the anxious or fearful timid group. Category 6, category 4, category 4, we have restlessness. And the question what you put forward is, what type of activity gives you the greatest pleasure? Riding, rocking, dancing, traveling, being carried if they are child, quick, hurried work, slow people get on your nerves. All these questions you can ask regarding the restlessness of the patient if they are belong to the restlessness category. Now the rubrics can be considered: carry, desire to be, dancing, excitement, excitable, hurry, impatience, restlessness, riding, rocking, quick, singing, time passes slowly, travel, desire to, wander, desire to. So all these are rubrics belonging to the restlessness category. Then we have the category 5, that's planning and thinking. The question what you might ask is, when are you in your happiest mood? What are the factors that add or take away the pleasure in life? So the rubrics belongs to this category is activity, ambitious, busy, clairvoyance, carefulness, conscientiousness, delusion, has neglected his duty, exhilaration, fancies, exaltation, fastidious, hopeful, industrious, optimistic, overactive, planning, precocious, reserved, responsibility, usual, unusual, aggravation. That's from Fatak's repertory. Serious, earnest, theorizing, work, desire for mental. Now coming to the category 6, that is lascivious nature or the lascivious disposition. The question can be, are you troubled by the thoughts of sex? In what matter and how often? And the rubrics will be amative, amorous, lascivious, naked, wants to be, nymphomania, obscene, lewd, satyriasis, shamelessness, thoughts, sexual. Now coming to the category 7, that's unsocial behavior. The question might be, are your interpersonal relationships with the members of your family or associates in the office or company or society smooth or strained? To what extent? What you consider deficiencies on their part disturb you mentally or influence your relationship or dealings with them? In what manner? The rubrics would be unsocial traits, company averse to, consolation, aggravation, disobedience, egotism, hatred, haughty, heedless, jealous, malicious, mischievous, moral feeling, want of, slanted disposition to, squanders, unsympathetic, vanity. Now, the category 8 and 9, which are unsocial traits and destructiveness, these cannot be asked by the indirect questioning, but instead you have to elicit largely by those details gathered from the relatives or attendants, because these are repetitive in nature. These won't be exhibited in front of you. The patient often might conceal himself from saying those things, but this can be better confirmed by asking to the attenders or the family members whether they have any unsocial traits or destructiveness which is manifesting in their life repeatedly in different situations. So that's how you confirm this. For unsocial behavior, we have these rubrics: abusive, avarice, aversion to members of the family, bargaining, bite, desire to, capricious, contradictory to speech, intentions are contrary, cruelty, cursing, deceitful, dishonest, eccentricity, estranged from family, greed, hypocrisy, insolence, kleptomania, liar, quarrelsome, rudeness, selfish, unfeeling, hard-hearted, ungrateful, unreliable. For destructiveness, you have biting desire to, breaks things, desire to, cruelty, deceitful, destructive, discontented, feigning sick, kill desire to, malicious, moral feelings, want of, mischievous, squander, striking, tears things, throws things away, violent. And coming to the cluster 2 category, of category 10, we have the sad melancholy disposition. So the question indirectly what you can ask is, what is the effect of grief, shocks, disappointments, and other circumstances on you? So depending upon the answers given, you can take one among these rubric. I'm not going to read each and every rubric because we are running short of time. I have to explain to you a 2 case so that you can able to understand the method easily. So kindly have a look on these rubrics, which is belonging to the category 10 of cluster 2 of sad melancholy disposition, right? Now, going forwards, we have category 11 of cluster 2, that is extreme effects. How do you ask the patient? Has there been any event in your life which has disturbed your mind very much? How have you reacted to them? How much are they affecting you today? And you can have a understanding of these rubrics, what you can take when the patient is going to give the answers for the questions what you've asked, right? So that's about the extreme effects, right? Next is category 12, dullness of the mind. You could ask the question, have you had any difficulty in understanding the matter you read or study? How is your clarity of thinking? Can you stand mental exertion? Any difficulty in remembering the names or what you have just read? This is the indirect way of questioning. And you can select one of these rubrics depending upon the answers that the patient gives you. That is regarding the dullness of the mind. Next is category 13 and 14. That's imbecile idiocy and mental retardation. So again, these cannot be what to say understood by one single sitting or one single consultation. Of course, you can able to note the imbecility idiocy in the patient's behavior, but you have to again ask the attendants regarding any kind of activities or behavioral changes which is exhibited in the family or in the instances real life situations, so that you can able to place the patient as belonging to imbecile idiocy or mental alienation, right? So these are the rubrics for imbecility. These are the rubrics for mental alienation. These are the next category, that is category 15, that's delusions. So you ask the question, do you have any fixed ideas, strong feelings or fears which your close relatives and well-wishers advise you to dismiss from your mind, telling you that they are not real? Depending upon the answer, you can select one among the delusions. There are many delusions which is given as a very big rubric in with the sub rubrics in any of the repertories. Here I have given only simple examples for making you understand, which are very common, right? So next is the 16th category, that is habits and obsessions. How do you question? Do you have any compulsive habits like taking alcohol, drugs, tobacco, smoking, or obsessive cleanliness resulting in constant washing of hands, or tormenting thoughts of various kinds? This you are asking. Depending upon the answer, you can select one among the rubrics. Just dipsomania, morphism, washing aversion to, or mania for likewise. Right. Next is category 17, causation, ailments from. Ailments from various causes may be inquired invariably in every case, depending upon the patient's actual life situations. So these are different causes or ailments from you can able to elicit from the patient. Many different categories are there in the generalities chapter as well as in the mind chapter, so that which you can have a look into. Last is the category 18 of cluster 2, that's aggravation and amelioration. The case is incomplete unless aggravation and amelioration are inquired in detail with respect to generals as well as to the particulars. So these are certain aggravation amelioration. I am very sure that you have much more ideas regarding this. Right now, coming to the real life case, how do you make this particular understanding? I'm giving a case example of case 1. That's case Vignette I'm going to give you. A lady accompanied by her elder sister aged 54 years, working as a teacher, was brought to the complaints of depression. So a lady, 54 years, working as a teacher, came with complaints of depression. She was not prepared to come to meet the doctor even to the market. That means the patient is not willing to come outside even. So I have taken the rubric going out aversion to, okay, which belongs to the cluster 2 category, right? And would sit down at home as if stupefied. Means she is going to have a vacant look. She is going to sit at the home. She is going to have a vacant stare. Okay. So I have taken this rubric, sit inclined to. She does not wish any company and was feeling better when alone. She did not like to talk even with her husband. So we have talk indisposed to. from the case description given by her sister. So I am now maintaining a passive stance, right? I'm just observing what the patient is doing. And now the patient is not saying anything. The sister is narrating the complaints because the patient is not willing to talk. Okay, by this we can very well able to understand that the patient is in a deep state of melancholy or sadness. So she belongs to, an opinion comes to mind that she might be belonging to cluster 2, category 10, that is sad melancholy personality. Clear? This is the passive stance. Remember, I'm just keeping quiet. I'm just observing what the patient is doing. I'm just observing what the patient's sister is trying to say to you regarding the brevity of the complaints of the patient. Now come to the active stance. Now I'm going to put forward questions to the patient. I'm asking, what was the reason behind these behavioral changes? Again, the patient is keeping mum. Patient is not uttering anything. The sister is saying, her sister replied that 25 years ago, her elder sister's only son, about age 20 years, committed suicide by hanging without leaving any clue as to the reason for him doing so. So now I have come to the understanding that there is an ailment from son's suicide, okay, or demise of her son, okay, the patient's son, who is age 20 years, okay, right. Now what is the category with which the patient belongs to? Again, cluster 2, but now category is shifting from 10 to 11, that is extreme effects, right? I told you always the patient will not come into a single category. The patient may waiver off to other categories as well. Now here the patient is shifting from category 10 to category 11, that is extreme effects, that is effects of death of her son, who is aged about 20 years, and this happened 25 years before. Now the lady is aged about 54. 25 years before, her only son, who is 20 years ago, 20 years old, died. Okay, right. Now does she show or express her grief now, even after 15 years of his demise? So 15 years have been over. Now does she express any grief now? Again, the sister is saying, the patient is not saying anything. She said no, but soon she corrected herself, saying that one day when she was taken to her friend's house about a year ago, she was asked how many children she had to how many children she had, to which she did not answer, but just lowered her head in a sad face, suppressing her tears. So that is grief undemonstrative. She was taken to one of the parties in her friend's home, and someone has asked the patient regarding how many children she has. They don't know that her only child has committed suicide. But hearing that, she felt depressed, she felt sad, but she had not exhibited the grief. She was having tears, but she is trying to suppress her tears. So here the rubric taken is grief undemonstrative. Grief is there, but she is not demonstrating the grief by tears or by weeping or by not talking likewise. What are the changes in her after the incident? What has happened after the incident? Her sister replied that previously she was full of mirth, but nowadays she is aversion to jokes. She does not like joking. So jesting averse to, that's the rubric. She finds it difficult to concentrate on her teaching work. She's a teacher, no? So now she's finding hard to concentrate on the teaching job, which is her profession. So I took the rubric concentration difficult. Every night she feels anxious as to how she will face the next morning's task of teaching in the school. Always, every day when she wakes up, she is feeling anxious that how can I able to teach the students today, because she feels that she could not able to concentrate well on her work, or she feels a lot of confusion and unrefreshed feeling. So we have here work aversion to mental. She could not even do the cooking activities. Her husband has to help her in the kitchen. So here we have the rubric intolerance aversion to work physical, right? Now taking all these rubrics into consideration, I have repertorized the case, and the case comes to cyclamen. Okay, cyclamen, when given in infrequent doses, has cured the patient of her depression. So this is one way how you try to apply this method. So first, passive stance, let the patient say whatever they want to. Try to classify the patient as belonging to any of the categories, whether on cluster 1 or cluster 2. Try to put forward questions just to confirm whether the patient is sticking onto the particular category or wavering off to other categories. Try to put questions indirectly to understand the patient's life situation. Try to convert them into rubrics once you are confirming, because ultimate judge is you only. And after the rubrics are taken, try to repertorize the case and you can get the simulum for you. Of course, resort to Metria Medical just to confirm whether your selection is right or wrong. So this is one way how you get into the mentals of the patient. I hope one more case is there, but we don't have time. So I would try to complete my classes with this particular case. So it will be easy for you to practically understand the way of utilizing this particular. I'm stopping my screen sharing here so that if you have any
Yes.
doubts, you can ask me.
Yes, definitely. It's a mind-blowing presentation from Dr. Balachandran once again. Really, this kind of presentation is the need of the hour because people are still, most of the doctors are struggling in the early part of their career, how to repetize in those cases, how to read the mind. But you have shown beautifully how to look into that aspect. Congratulations once again. And those who want to participate in discussion may please raise your hand. Or those who want to participate, having any doubt, can also raise your hand. Yes. Doctor, what's your experience in your present post? What kind of thing you are doing there?
In AIMS, Patna,
Yes, exactly. Whether it
uh,
is a research purpose post or some other.
no, research has not yet been initiated, but we are working into the pilot study regarding the cases, how we try to get in Bihar. What I find is the cases of Duchenne muscular dystrophy, that is DMD, is on the rise. There are much more patients coming to the Ayush department for consultation, as they don't have any medicines in allopathy as such for treating the cases of muscular dystrophy. So that's one case what I find. And we have many challenging cases as well. We have venous ulcers, we have hyperthyroidism, endocrinal diseases, diabetes mellitus, sinusitis, childhood asthma, and a lot of lipoma cases. So we are seeing almost like every day 60 patients as in the OPD.
Uh,
Previously, when I joined in 2021, it was around 10 patients per day. But now, because of the rigorous effort put forward by me as well as by my colleagues, the patient presentation have increased from 10 to 60 patients per day today, as of today.
oh,
So every
okay.
year, the number of patients are increasing.
It belongs to central government.
Yeah, it's central autonomous, just
Yes.
like your CCRH, just like the NIH.
Okay.
So like
Then
this, central autonomous system.
whether who is the head of the post, whether the director or director general or like.
Director of AIMS is Dr. Gopal Krishna Pal, Dr. GK Pal. He is the director of AIMS Patna. He is
Yes.
an allopathic faculty. He is a professor of physiology. He was from JIPMER.
Okay.
So
How many homeopaths are working there?
only two, sir.
Oh.
Myself as well as my colleague, Dr.
Is
Manjurani
there
Maurya.
any Ayurvedic doctor there?
Yeah, Ayurvedic doctors are there. Three medical officers from Ayurveda.
Okay. Thank you.
So
Thanks for the information. And now it's up to Dr. Ram Paresh sir to say vote of thanks to the session.
Thank you, Dr. Dhaneji, and congratulations, Dr. Balachandran ji. Very thanks. Excellent session. According to law of homeopathic science, mind is a very important and how to utilize mind rubric. Very thanks, Dr. Balachandran ji. You are posted AIMS Patna. I am live at Supal. original house Patna, Mussoorie.
okay.
Dr. R.P. Saha, Mussoorie.
Okay, sir.
Very thanks, Dr. Balachandran ji. Excellent session. Behalf of IFPH, very thanks again presentation. And every presentation is a very nice presentation. Excellent session.
Thank you, sir.
every thank you, very thanks. Kindly share mobile number.
Yes. Sir, it is there in the poster. It is there in our poster.
Thank you.
Yes. Th Thank you, Dr. Rambaresh, sir. And
Thank you.
uh, thank you, those who participated in the session. And Doctor, once again, we are thanking you, Dr. Professor Balachandran, for this wonderful evening with us. Thank
Thank
you
you,
all.
Dr. Dinesh. Thank you.
And tomorrow we will have a session from Dr. Kathim Lemon from USA. And Doctor will be talking about the solid medicine of homeopathy. With that, we come to the end of the day, 1,490 3.
Thank
Thank you all. Good night. It's over to Dr. P. Shaila to moderate the Malayalam session.